Good morning, everyone. Good afternoon, good evening. A very warm welcome to today's webinar entitled Exploring AI Innovations in Predicting and Preventing Obesity-Related Vascular Disease. This webinar is jointly organized by the European Society of Radiology and the European Institute for Biomedical Imaging Research, EIBIR. So this is a very exciting agenda with many lectures where you will learn a lot about early risk prediction to decision support and citizen health empowerment. And today's talks will highlight the key innovations from the AI Pod project. What is that? That's a European initiative that brings together all experts in imaging, data science, and clinical medicine to develop trustworthy, human-centered AI tools for vascular health. So I have invited an outstanding faculty of the experts that are involved in the projects. And you can see that they will, I will propose that they first give their lectures, and please write down your questions. So in the end, we will have a question and answer moment, and you can ask everything to the experts. So my name is Regina Beets-Tan. I am the scientific director of the EIBIR. I'm happy to welcome Anastasia Bartashova. She is the Deputy Project Coordinator from the Division of Cardiovascular and Interventional Radiology in the University of Vienna. George Langs, who is the founding director of the Computational Imaging Research Lab at the Medical University of Vienna. Jan Kirchhoff, who is the who is a co-founder and executive director at medicalvalues in the Netherlands. Then we also have Fabio Catarinelli, who is the Chief Medical Information Officer of the Brightfish groups, and Saif Al-Basri, the postdoctoral physician at the University Clinicum Bochum, and finally Eva Steijvoort, a postdoctoral mandate at the Center of Biomedical Ethics and Law, Department of Public Health and Primary Care in Belgium, Leuven. So without further ado, I would like to invite Anastasia to hold the first lecture, the Trustworthy AI for a Healthier Future, the AI Pod project. Please, Anastasia, take the floor, and I will stop sharing now.
I'm taking over right away. So you should be able to see my presentation right now. A very warm welcome from my side as well. It's really a pleasure to have you all joining us today. As Regina mentioned, I will give you a short overview of the project, tell you a little bit more about our vision. So the overall motivation of the project. Cardiovascular disease remains one of the leading causes of death worldwide. At the same time, obesity is increasing at an alarming rate. And together, these two challenges represent not just a medical issue, but a societal one. Yet we also, not just to stay very negative, live in an era of unprecedented opportunity. Artificial intelligence gives us the ability to see patterns, predict risk, and personalize prevention in ways that were unthinkable only a decade ago. This is exactly where the AIPod project comes in. Our vision is simple but ambitious: to use trustworthy AI tools to detect cardiovascular risk earlier, particularly in people living with obesity. By combining photon counting CT data, lifestyle data, and Fitbit-based activity tracking, EIBIR develops tools that can predict disease progression and help guide preventive care. The EIBIR risk score represents a new model of healthcare innovation, one that's not just data-driven, but also human-centered. It's about using the newest technology, such as AI, not to replace clinical intuition, but to strengthen it. And ultimately, to move from treating disease to preserving health while empowering patients to take charge of their own health. And as you can see here, our project is based on two parts. One is the retrospective study, which forms the basis for the risk score development, and the proof of concept study, which tests our tools in a real world setting, in an observational study, combining all the critical data in one representative tool, which is supposed to predict risk of cardiovascular disease more precisely than it did before. Today, you'll hear from our experts who will dive deeper into how we're building these tools, how we are validating them, ensuring that they are trustworthy and effective in a real-world setting. With that, I'm really thrilled to hand over to Georg Langs, who will take us into the heart of the iPod project and tell you a little bit more about the technical side of it.
The floor.
Thank you. Thank you, and I hope you can see my slides. So thanks a lot for the introduction, and thanks a lot for allowing me to be part of that webinar. So my name is Georg Langs. I'm from Medical University Vienna, and together with a great team over the project partners, we are focusing on developing the machine learning methods behind the iPod score. And just to give you a bit of an intro, the goal of the score is to continually estimate the risk for cardiac events in citizens, they are sometimes not yet patients, and we want to stay them that way. And so the idea of the project is to combine very high-end clinical data, for example, computer tomography data, with other clinical variables like laboratory variables, all in all, giving us a profile of the patients that characterizes them very well during one clinical visit, and then combine that data with data that we can acquire on a day-to-day basis while patients are not, or people are not in the hospital, like, for example, fitness trackers, dietary information, and so on. And the goal of the project is to create a risk score that, first of all, is more accurate than established risk scores that are based on a couple of variables. And the second goal is to not only provide those risk scores to doctors, but provide them also to people, to users of this app, to users, to patients, so that they can use that risk assessment in a day-to-day fashion. For example, by informing them, well, a certain change in behavior would change their risk profile in a certain way. Right now, we are at the first phase where we are actually doing the machine learning work on, first of all, combining imaging data with other clinical data in order to get an improved risk score. And then the next step, combining this clinical visit data with the day-to-day variable data in order to get kind of a continual risk score. Both of those are novelties. Both of that are something where we are learning new relationships between data that we can exploit in order to improve the risk score. And in the next couple of minutes, I'd like to give you a bit of an overview of where we are and also the scientific challenges that we have encountered. Just to give you a bit of a navigation help where we are. So there are two parts of the risk score. One is we are using the clinical data, the laboratory data, the imaging data in order to predict the risk of a cardiac event in a certain time frame. And this gives us a first risk score that is pretty standard in terms of where it's used. It's used during the clinical visit. And the second part is to combine that with these more continual measurements that might be a lot less kind of deep and a lot less in terms of dimensions than the clinical visit, but which give us information on a day-to-day basis, and we would like to combine them to a joint risk score. The infrastructure behind the project, I think that's not directly the algorithm, but it's important to understand it in order to understand also the setup of our algorithm and the decision support system that Jan will describe later on. So we are connected to hospitals, we are connected to the phones of the participants in the current study in order to collect this data and in order to be able to combine this data. And the risk score that we are developing is first of all delivered back to the clinicians that are using it in order to be informed during the visit of the patient, but it's also fed back to the citizen app that is being used by the patients, by the individuals that are part of the study, and then later on part of the users that are informed by this risk score. The overall challenge, and what was novel for us, many of us coming more from either a laboratory value background or an imaging background, was that there are a couple of streams that we have to combine. So first one is imaging features, right? Cardiac imaging, computer tomography imaging, the anatomy, the shape of the anatomy, the texture, and the features of the cardiovascular system, laboratory features that are also very informative, and we have to start to learn how to combine those two, clinical variables that are in themselves very predictive, and then these more continual variables that are acquired on a day-to-day basis and are kind of continually changing our risk assessment. Right now in this talk, I'd like to focus on this first part. How can we get imaging data and use it for the prediction of risks of individual patients? And I'd like to highlight a couple of challenges that we have encountered and a couple of problems that we have solved by now through the project in order to get data and in order to get features and information out of the imaging data that helps us to create this risk score. And I think one overarching theme here is that there are a couple of variables that we know, right, like coronary artery calcifications. We know about them, that they are related to risk, but we believe that there are other features in the imaging data that we don't yet know about, but that might also be connected to risk. And we would like to use machine learning in order to discover these other features and in order to quantify their relationship to future risk, knowing that while coronary artery calcification is fairly straightforward to assess, these other features might need some machine learning in order to get them out of the imaging data while they are still pretty robust. So let me dive into a couple of the topics. The first topic is having a very robust and accurate segmentation of the anatomy. So we are here working with different segmentation algorithms. There are by now foundation models out there like Total Segmentator that are very well suited in order to segment these anatomical structures. Two lines in which we went more in order to get to an accuracy that we need in order to quantify features that we want to use for risk prediction is one, getting the segmentation to an accuracy, especially the vascular system segmentation to an accuracy that is good enough so that we can quantify changes, so that we can quantify subtle patterns. And the other point is to not only segment, to not only say, well, that's the heart, that's this chamber of the heart, that's this vessel, but also to have a reference system that allows us to kind of pinpoint specific locations on a valve, on the heart, on the cardiac surface, so that we can compare the specific positions across the population in order to say, well, there are certain positions on the cardiac systems that are particularly informative regarding future risk. And Ben Glocker's group at ICL has focused on this combining segmentation with, we call them atlas learning approaches, because essentially we have an atlas of the heart so that all of the patients are mapped to one atlas, and that makes them comparable so that you can say something about specific locations. One of the themes of the project is trustworthiness, and trustworthiness also very often is connected with certainty, right? So we know that machine learning makes mistakes. We know that these algorithms are very good sometimes, but sometimes they fail to segment accurately. And in this work, we are focusing on not only segmenting, but also telling where this segmentation is certain and where this segmentation is less certain. And that's important as soon as we want to combine the measurements that we are getting out of the imaging data with other data, right? Because if we are pretty certain about the relationship between the specific laboratory parameter and risk, and some of the image measurements come with high uncertainty, then we might kind of shift the attention in this particular patient to relying on the laboratory parameters in order to predict the risk. That's one role of certainty. The other role of certainty is it also gives us a hint where things are out of the ordinary, right? So if an algorithm is trained on lots of examples and it's suddenly uncertain in a specific area, that might be a hint that in this area there is something that is not normal, that there is something that might be linked to risk itself, right? So uncertainty for trustworthiness, but also for feature discovery. The second line is, and that is coming up, has come up during the project runtime, so that was not really around to that extent when we wrote the proposal, but I think that's also the exciting part about these kind of projects, is that we are now starting to not only be able to segment, but also to create, right, to generate imaging data. And that's again our work from Ben Glocker's group, where we can generate imaging data, but we can also play through what if scenarios, right? We can take imaging data of the patient and then say, well, what if these patients were sick, or what if this patient were healthy? And that allows us again to compare healthy what if scenarios with the current status of a patient to see where we see deviations or where we see trends happening over time. And overall, we are right now at a state where we can perform the segmentation fairly accurately, also of the cardiac system, but also on the vascular system, and having that as a baseline, but also starting to use that as a feature extractor for the features that we are using for prediction. The second topic, and again, that's linked to trustworthiness, but also just algorithms that work, is that we realize that, of course, there is some heterogeneity in the data. And part of that heterogeneity comes from the patients. Part of that is just standard variability. Part of that is linked to the disease, but part of that is also linked just to the machinery that we use for data acquisition. And so we have invested in understanding better how to compensate for that. And one of the approaches that we have been experimenting with is continual learning, where we are continually adding training examples from the current data stream in order to improve the performance of segmentation models on new scanners, on heterogeneous scanners, on multi-center data. And here's an example where you see a timeline for scanners. The segmentation algorithm works well on the first scanner, but then it starts to deteriorate as it goes from scanner to scanner. And in the new, like in the fourth scanner, we have already quite a lot of false negative and false positives in this cardiac segmentation. And we can compensate that by choosing additional samples from the data stream, using the internal representations of deep learning models in order to choose which of those are good training examples. And by this, we can continually kind of adapt the model to changing hardware and keep it up to date, so to say, keep it continually learning to adapt to the circumstances of the data acquisition. All of that now is the basis for two things. One is we would like to discover new markers. And here is one example that is a representative where we are looking into anomalies. So there is a family of models, a family of research directions that goes into not saying, well, these are a couple of example lesions, let's find similar lesions in new data, but rather, well, these are examples where everything is normal. This is in new examples. Do you see anything out of the ordinary? And one of the big challenges in this line of work is to scale it to high resolution three-dimensional data. And here we are working with kind of detecting anomalies in different projections and then composing these projections to a 3D view of the anomalies in this imaging data. And some of these anomalies we know, right? Coronary artery recalcifications, but some of them we don't know, like subtle shape changes, subtle changes in the muscular tissue that we can see in this imaging data. And the last step is the actual prediction model, right, where we are now starting to fuse these different modalities, data that we get out of the imaging data, data that we get out of the laboratory data, and also the clinical history of the patient. And the direction that we are right now working on is to fuse that on in an end-to-end model approach, where we believe that, first of all, the models are at the status where we can represent the variability of the data in very kind of bottleneck feature representations. And here, what you see on the right-hand side is just a demonstration that these feature representations are good enough in holding the information about the actual image, right? So on the left-hand side, you see the actual image. On the right-hand side, you see a reconstruction of the image. Left-hand side, the segmentation. Right-hand side, the estimate of the segmentation that is generated from some latent feature representation. And the interesting part right now is to combine these feature representations and see how feature representations of laboratory data, of clinical data, of imaging data are connected, if there are any causal relationships, and especially how we can use these features that are coming out of very heterogeneous, sometimes very unstructured data, like, for example, written reports, in order to predict the probability of an event happening in the future of this patient. So to summarize, right now we're in the middle of the project. We are developing algorithms to grab data, grab information from imaging data, laboratory data, clinical data, and combine those in order to perform the prediction. This prediction modeling is what's going on right now in the model. And with that, thanks a lot for the attention. And I think there is a minute for questions. Thank you.
Wonderful, George. Thank you so much. Very interesting that this is going to be the future. I think I strongly believe this will be the future. So let's move to Jan, who will share with us the building of smarter tools, AI pod clinical decision support system.
Thanks a lot for the handover and happy to present. So maybe a brief background. We are a team based out of Germany and are working in the field of clinical decision support. And we have a medical device in the market, so software as a medical device. More on that later. Why does it actually matter? So one number that is fascinating to me is that medical knowledge doubles every 70 days. So that's an absolutely crazy number. And the one idea of clinical decision support is to make this knowledge available to all people. What are some core ideas behind clinical decision support? So there is the knowledge-based and the AI-empowered machine learning. As you can see, AI pod is a lot about AI. But nevertheless, there's the 5 rights of clinical decision support. So first of all, deliver the right information to the right person, clinician, nurse, whoever, in the right format. So it could be a dashboard, an alert, through the right channel, is the physician at his desktop or at her desktop or mobile, and at the right time, so at the right moment in the workflow. And that is also the idea of AI pod, to do these 5 rights right. The AI strategy that we currently work a lot on is a mix of rule-based insights, traditional predictive models, but then, of course, we are trying to incorporate more and more of the models that, for example, Georg's team builds. When it comes to medical device operational AI, it's really important, if you want to make it work as a medical device, to put in safety nets, because you really want to ensure that you have the best quality of algorithms and you can version it to enable medical device certification. So for the AI pod, as you've seen before, it's all about multimodal data fusion. So we have integrated inputs that are then combined into precise clinical decision support recommendations that we deliver to the physician. How does it look in practice? So here on the right-hand side, you can see the current version of this AI pod dashboard. Obviously, we are still in the progress of the project, so we will continue and build it out. And as you've heard earlier, it's very important to be as explainable as possible to the physician. So you really want to make sure that wherever it's possible, we can explain the reasoning, the logic behind our scores and provide a confidence with it. What are some challenges when it comes to AI implementation? So overall, although there's a lot of presentations about it, AI clinical decision support is still quite early in the progress. So in a lot of hospitals, healthcare systems, we are still fighting the paperwork. However, AI decision support systems are growing in adoption. And what's important is that it needs a strong evidence base. So projects like AI pod deliver a huge benefit to improve this evidence base and make sure that it's actually trustworthy AI that's being built. Talking about what it takes to make it work in the healthcare ecosystem. Another part is the regulatory piece. So here it's important that you, of course, comply with GDPR, data protection, data privacy. But as soon as you deliver clinical decision support, so you manipulate data, you're oftentimes classified as a medical device, which means you need to comply, you need to have a governance body. And this is one thing we bring to the project, is we have software as a medical device in the market and really are delivering our input to this project. And what's interesting from an EU perspective is that also the European health data space fosters this exchange of health data and also make sure that there is, for example, alignment with the AI Act and such bigger topics in this important world of AI. What we also believe is that the AI project is a bigger picture of clinical decision support as part of learning healthcare systems. So as we want to have this continuous improvement circle, we want to make sure that the feedback data is fed back into the model. So the more the system is being used, the better the quality will be over time. And of course, the goal is also to measure the clinical outcomes and to then continuously adapt and improve the AI pod clinical decision support software. What are some future topics? AI, in our opinion, delivers tangible benefits in combination with clinical decision support. So of course, it's about improved diagnostics, better patient outcomes, but after all, it can also have an impact to reduce the EU health costs and enable the best possible health protection for all EU citizens. And the good thing about digital tools is that they can also be used on a large scale, potentially also in rural areas. So the key takeaways: clinical decision support market is still early, especially in the AI space, but it's maturing. What's special about AI pod that it's multimodal and really focuses on the clinical value. AI pod is a cohesive solution with multiple partners involved. So the clinical decision support, for example, works closely with the patient app and other pieces to have this one holistic picture. And last but not least, we're not using AI for the sake of using AI, but for the impact for the physicians and for the patients and a better care. With that, thank you for your attention and looking forward to your questions.
Very clear, and again, a very important topic, the clinical impact. So I would like to move forward to the next speaker, Fabio. We are very much ahead of time, but it's good because then we have more questions during the panel discussion. And please, attendees, I encourage you to ask the questions or to collect your questions and ask it to the expert. So please, Fabio, take the floor with your lecture, AI pod Citizen App Features and Functionalities.
Thank you for the introduction. Do you see the right screen or is it again on presenter mode? It's good? Okay. Yeah, great. Then, yeah, thank you. I'm going to tell you a bit about, because I only have 10 minutes, so it will be a bit about the Citizen app that we have in this project. And I want to start with this picture, which looks quite complicated, but in reality, it's not that complicated. So Jan already spoke a bit about the clinical decision support system. And we are the conduit of that system to the patient. And we are doing two main things. We are collecting data and we are showing a bit of data. So let me break that down for you. So the citizen is going about their day. And during that day, we collect some information about them. We collect their physical activity, some data about their heart rate. We register when they eat or drink something, and we send them periodical questionnaires about their quality of life, how their well-being is, etc. And that data is then fed into the CDSS. Some AI magic happens, and a risk score is coming back. And that risk score is then also shown back to the patient in the app in a patient-friendly way that a patient or citizen, I should say, can understand and can act upon. So the purpose of this app, if we break it down, is threefold. So the one purpose is the monitoring of the health of the patient per citizen. Another very important purpose is the patient-provider communication. So the data that we gather and also the insights that the user gathers is then fed back to the physician, nurse, physician assistant, and everything in between. It helps them a lot. Many studies have proven that informed patients are actually more compliant and actually follow up better on what a doctor prescribes. And the users receive tailored personal health advice. So the idea is that if you behave nicely, you stop smoking, you eat and drink better, then your risk score will go down, and you will see this reflected within the citizen app. A bit more in depth on the technical part. So the challenge of this whole project is that we are one of many building blocks. We are almost a Swiss watch with a lot of moving parts, and we have to integrate with a few systems. And to make that happen and to make it successful, scalable, and manageable in the future, we stick to a few standards. I will not go in too much depth, but some of the things we use here are Fire, Loink, and the SNOMED coding system. And we do this to ensure that in the future, if we would connect to another application or if we would connect to another system, we can smoothly exchange data. We have no trouble with translating things or having to recode things. So we are preparing it a bit for the future. So the app itself is, of course, the most interesting part of this talk. The application itself consists of 5, you could say, elements. So it has 5 tabs in the bottom. The most important one is activities. This is where the user will see, and the user in this case is a citizen/patient. They will see a timeline which is personalized and which is moving along as time goes by. So they will see tasks here, they will see educational content, everything that is important for them at that moment in time. There is a dashboard tab, which shows them their visual progress. It shows them the risk score. It will give them visual cues on how they are doing and what they need to do. For some reason, these two are flipped, but there's also a records tab. This is where they can literally see their raw input and the data they have given to the application, more for records keeping than for daily use. And then the last two are profile and information. Profile is very boring. This is where they maintain their user settings. Yes, no to notifications, email address, personal stuff that they can change or not change. And the information tab shows them the study information, what to do when they have questions, what are their rights, what is the purpose of the study, all those common things. See it as a library of information. Some things that are special in this project, because a citizen app itself is not that special, but what we are doing here is quite interesting. We are, so at first, we are using patient-reported outcomes and experience measures. So we send the patients validated questionnaires that are scientifically validated. So the scores that can come out of them can be used to, for example, predict outcomes or to track outcomes. That is one part. Then we are linking the app to a Fitbit device, which is gathering steps, heart rate activity, etc. And that data is then combined with the questionnaires and sent back to the CDSS. And this might sound simple, but linking to a wearable on such a scale and do it in a safe and secure way, and at the same time complying with all the rules that we have currently in this world is quite an interesting feat on its own. And lastly, users can also voluntarily add more data at more points in time, which we stimulate them a bit to do, of course. And this even broadens the picture that we have of all these participants. Like I said, one very important element here is how to keep your users engaged, because people do not like questionnaires. People do not like to do repetitive things, so we have to give them a big carrot to make them use the app. So one element is this personalized timeline. People like that it changes along during the time, so they come back to it. They keep looking what has changed, what is new, what do I need to do. Also, something that is very important for most people is their health. So when you start giving people health guidance and you give them recommendations and forecasts, it becomes more of a game for the user, and they also keep coming back and keep using your app. And lastly, something you need as well is repetitive notifications of things. So we try not to spam them too much, but they will get push notifications saying, hey, there's a new task for you. Hey, you haven't looked at the app for 7 days. You should have a look. Perhaps something is there. And these three things combined are what we are trying to do to keep the user engagement high. Now, the most boring, but also the most important topic is security and trust, because I think this is the part that has led to the most discussions within the project until now. Not necessarily with the project members, but mostly with the different departments that handle this topic in the universities and hospitals. Because we have created so many laws, rules, directives, and guidelines that even a lawyer in a hospital sometimes has trouble to navigate that. And we try to make it as easy as possible. So, for example, there is no username, there is no password, there is nothing to remember for the patient. When they are included in the study, they get a QR code that is for them personally, and that code is then used to link the app. That is it. So we, as a app provider, we do not know anything about our patients besides this individual identifier, which is totally unusable for us. The only part where it comes together is further on in the ecosystem. Basically, only the recruiting center can eventually trace back which natural person is behind that ID. Nonetheless, we also allow the citizens to lock this app. They can use Face ID if they have an iPhone. They can use Touch ID if they have an iPhone. If they have an Android, they can use the same things, but in Android, everything has a slightly different name. But they can use their fingerprint or their face if they want to lock and unlock the app. And this app, we can argue about it, but we chose to give it a CE marking. So the app is registered as a Class 1 medical device, which also helps to put certain people at ease a bit. But it also means that we comply with the GDPR. It means that we have a very strict data protection, how do you say this, protocol in place. And we do all the things that we should do to keep the user safe and secure. And I think this was also my last slide. 9 minutes and 40 seconds. So we have 10 seconds left for questions.
Minutes, 10 seconds left. So I would like to move and introduce Saif to share with us his presentation from prediction to prevention, how AI pod supports better vascular risk management. Please, Saif.
So, hello, everybody. I'm just preparing the presentation. I'll be sharing it with you in a few seconds. So, there is no. Okay. Nobody sees my slide yet, right? Not yet. So I'm trying again. Almost there. Sorry. No? Okay. So again, good day, everyone, and sorry for the late seconds. My name is Al-Basri, and I am a physician and postdoctoral physician from Bochum, Germany, and part of this project. And as I will be focusing on support how this AI pod project supports a better vascular risk management. And Professor Langs and colleagues already covered some technical aspects, but I will be focusing on some important ideas from my perspective also as a physician, and my colleagues can understand the relevance of this project. So before we tackle a problem, we have to address the problem very well. And the thing we have right now that these prediction tools we are using as physicians, they are not sufficient enough to predict or to prevent very famous and diseases like are challenging to us. So if you take a look at these charts from the WHO, cardiovascular diseases are the leading cause of death globally. And you can bear in mind that about 60 million people die every year, and around a third of them die from cardiovascular diseases. And these data are from 2022. And one of the key features that we see that most cardiovascular diseases actually can be prevented, as mentioned by the WHO. And this is very important information. I'm going to come back to it later. But guess what? And let me hit you with the truth bomb. It is 2025, and cardiovascular diseases are still the #1 killer in the world. And according also to the World Heart Federation and the WHO. So it seems like we have AI, we have more data than before, we have all these new tools and measurement, and we're swimming in information, yet it seems that the cardiovascular diseases are a trouble and a challenge to us, to the patients, and also to us doctors, because we are under pressure to provide modern solutions and prediction, a better prevention. And I told you that if you take a look at the fact, I'm going to come back to the slide before, that most cardiovascular diseases can be prevented. This is indeed the fact that if you see unhealthy diet, tobacco consume, harmful use of alcohol and drugs, air pollution, inactivity, overweight, obesity, and so on. These factors can be prevented, and globally in a systematic way if we engage the patient directly. So the thing is, or the problem we have right now, is that we are using tools to predict risk that are designed in the 90s and about 20 years old. So it's like imagine like NASA is trying to land on Mars using Windows XP to run the mission. It would be outrageous in the technical bubble, and it's understandably. So we need, these scores are not really bad, they are actually good, and they do provide some estimations. However, they are very static scores. And we have to bear in mind and that health itself is actually a dynamic process. So traditional models or scores do not mimic this fluctuations and dynamic changes in health. And the thing is, the new thing in modern day is that patients are evolving, and we have so many tools to track data, health data, information, as we mentioned before. You have the watches, we have the sensors, and patients are actually swimming in information. We too, the problem is we have, and that's the key message, is we do not have a data problem, we have a translation problem. And the question is what AI pod does. It basically tries to provide a navigation tool that we interact or integrate all these wearables, these data used by patients, and also the imaging data, as my colleague described before, to create a real-time alert and triggers us physicians to take actions, to navigate the patient in the right trajectory. So let me give you an example. Like if you use a normal scoring system, like SCORE2, it's a very often used score in the cardiology. It maybe labels a patient as a moderate risk patient. But if AI pod algorithm might predict that this patient, or might detect that this patient has a high level of inflammatory markers, for example, or his HbA1c is very high. In this constellation, this algorithm might help us to label this patient as a high-risk patient, and that's what enables us to take direct action and intervene and maybe suggest a better treatment for this patient. So it's like a real-time projector. So imagine you want to have a run. And to go for a run, do you like to have an application that shows you a static estimation of the weather in the next 3 weeks, with an estimation weather, or do you want some application that shows you the possible changes in the weather in the next hour, in the next 2 hours, in the next minutes? So probably you can adjust and wear the right suits for that. So what we are trying to do by AI Pod, and that's what is elegant about this project, is that it tries to create a weather forecast for your own body. So just to simplify the idea. And here's a basic comparison between these two models. You see on the left side, you have the score risk 2, and it estimates the 10 years cardiovascular risk. You see, it also divides the patients in low, moderate, high, and very high category. The thing is, on the right side, we see that any new AI algorithm, it's very dynamic, and it probably could detect any changes and fluctuations in months or maybe weeks. However, the most elegant thing is, you can see on the right chart, is life itself is not easy predicted and very changing. Some maybe the patient decides to do more workout, or he gets infected with a very bad disease or bad infection, very serious infection, or maybe he gained some weight after before the end of the year, or he's changing his habits, or maybe someone could be also positive. He tries to change his nutrition, or he has stress in the work, or gets pregnant, and so on and so on. So the idea is we could navigate through these changes way more and faster, and also try to calculate risk very dynamically. So I'm going to just cover up the AI pipeline, which was also covered by my colleagues. Basically, we take these clinical data as imaging, omics, and wearables, and we try to extract the features we need to cluster the patients in categories that are easy to handle and also very individualized. Like these clusters and these data enable us to guide the patient, or maybe predict many possible outcomes specified or specific for this patient, and maybe suggest, and this is the extrapolation of new treatment modifications, and maybe we adjust our strategy with him and tell him, look, you have a very high level of LDL, or maybe you have a very high level of glucose intolerance, so let us take a different treatment approach than the usual one. And that's the individualized process we are interested in. And this is going to change medicine. It's basically not a one-size-fits-all. It's a very individualized process and extremely modern. And this is actually the basic idea of using AI. So creating this dynamic real-time system to prevent diseases is an elegant way to change a patient's life. And I think to us physicians, it is an opportunity to engage with this informed patient and also develop better health for all. Thank you.
Thank you. This is excellent, a perspective on the clinical impact in the future. So we move on to the last lecture from Eva, Human-Centered AI, Stakeholder Perspective on AI for Imaging-Based Prediction of Obesity-Related Vascular Diseases. Please, Eva, take the floor.
Can you see my slide? Okay, thank you so much. So, good morning, everyone. My name is Eva van Steijvoort. I'm joining from Belgium today. So I will be talking about a study we did where we engage with different stakeholders on their perspectives. We come from an ethical background. I know sometimes ethicists have the reputation of being very critical. I just want to underline that the messages that I will be giving today are based on the interviews that we have done with diverse stakeholders, and it's not only critical comments, it's really meant also to help AI-pods and also future-oriented projects that are working in the field of AI-based risk prediction. So within AI-pod, we have been involved from the very start, and I think that's a really added value to be already on board early on in the process. Where AI-pod is developing AI-based risk prediction tools. And our study objective with the study that I'm presenting today was really to explore stakeholders' perspectives on potential benefits, concerns, and implementation challenges related to the tools that are currently being developed to inform, of course, the future development of these tools while the project is ongoing, but also future AI tools in healthcare. I think AI-based risk prediction is a very hot topic nowadays, but it's important to engage with different stakeholders, and our consortium is already very multidisciplinary, but it's also important to talk with people that are not being present, of course, in the consortium. So what we did interviews with key stakeholders like clinicians, AI experts, but also patient representatives, policy makers, etc. We performed these interviews early 2025, so in the beginning of the year, and we provided inductive content analysis based on the data we collected. So just to give you an overview of who we talked to. So we talked to 21 participants. People had a background in radiology or AI, but also social sciences. We also talked to patient representatives, a GP, also people with a background in law and policy. Of course, qualitative research is more exploratory. It's not meant to be generalizable. But it still gives a good idea of potential concerns and benefits stakeholders might perceive. So we had a response rate of 36%. Most people we interviewed were located in Belgium, but we also had some participants from other European countries. We had both people from the AI-pod consortium that participated, but also external stakeholders. And out of the 21 participants, 12 were female. So just to start out, overall, participants were quite positive with regard to the tools that are being developed within the AI-pod consortium. Both the clinical decision support system and the patient app were seen as supportive instruments in clinical decision-making that had an added value to current practice. Some participants highlighted that longitudinal monitoring of patient health data would really make a difference. But also what was mentioned before, the integration of multimodal data, both clinical, lab, imaging, and lifestyle data was really seen as a positive aspect to provide more accurate risk prediction and also insights that are really data informed. Also, the fact that the risk prediction scores would allow improved cardiovascular risk stratification was also mentioned, I think, by some of the colleagues before. So to identify these patients with a low or a high risk, that would also allow to identify those patients that would really benefit from more intense follow-up. So one participant highlighted, I think it has a lot of value for physicians. Currently, they only get snapshots of someone's health. If you can measure certain parameters continuously, it might lead to new insights we didn't have before, especially when adding the lifestyle data. Other benefits also, some are repetitive with the previous presentation, but just to show that stakeholders also perceive this, the option to have improved patient engagement, to really provide these tools to improve health literacy, and also to allow patients to self-manage their health better, and also more reliable data. So quite often in the clinic, this was voiced also by several people active in clinical practice. They have to rely on data that are self-reported by patients, which might be less reliable or incomplete. So the fact that there is continuous health monitoring with Fitbit watch, for example, could also provide more reliable data. Of course, there were also some concerns that we have to, I think, acknowledge and take into account for the future. The fact that these tools might be perceived as burdensome or overly controlling was voiced by some participants. Patient representatives were also the two we talked to were a bit, yes, one person said this could be an option, the other one didn't really perceive it like this. But I think it's something that we have to take into account for the future, and also think about ways how we might mitigate this. Also, the fact that people, when they are being confronted with a risk score, that this might also cause anxiety, and as a negative effect, that this might undermine the motivation for behavior change. So again, here it was also voiced that the whole context, the framing and the communication towards patients would be very important if you provide risk scores, so patients know what to do and know what they can do to manage that risk score, to avoid unnecessary anxiety. So one participant voiced, I think being confronted with it day in, day out might make it psychologically heavier for people. For others, it might be motivating. It's important to monitor how patients react to it. So really also highlighting individual responses of patients. So patient A or patient B might react differently, but this is something that you should also then monitor. Other concerns that were voiced during the interviews by participants is, of course, the awareness of weight stigma, especially in the population of patients living with obesity. Depending on how the information would be framed, it could reinforce weight stigma if there would be too much focus on weight loss. Then again, some participants also voiced that this would be an opportunity also to mitigate the stigma by reframing the message to overall health needs and overall health instead of solely focusing on weight. Some participants were also questioning the utility of risk scores, especially like one of the participants, a GP, said, okay, we have evidence that some evidence that lifestyle advice could work, but actually what we know at the moment is still limited. So there would be a need to also perform more research on that. I think especially in the patient population living with obesity, it's quite hard sometimes also to change behavior and to have long-term outcomes that are better for their health. So the question there was like, to what extent a risk score would really help these patients. Also, access barriers is something I think that is also being seen within the consortium. So the digital divide, the digital literacy, especially if you have a patient cohort that is a little bit older, that doesn't always have the latest smartphone, and that potentially new applications might not be compatible, but also language constraints. These were all barriers that were also seen in previous studies or previous experience with apps in the clinic. Very frequently also clinicians we interviewed or people in practice, in clinical practice, made a reference to the tools that are being used to follow up on patients with diabetes, where they already have this experience also. But again, very depending on the individual patients, of course. And if you talk about AI-based risk prediction, very often the topic of the black box topic also came up, and the trade-off that you are making between accuracy and explainability in practice. It's both related to patients, but also healthcare professionals that would be using these tools. So, like I said before, so the utility of the risk scores and the importance for personalized lifestyle advice. One participant said, from an evidence-based standpoint, we know a few things about lifestyle, but if we talk about the things we are completely sure of, that's quite limited. And because of that, it's quite difficult, because in a system like this, you want to provide concrete advice, but the more concrete you go, the further away you get from what is actually scientifically proven. So I think there's also an area where we probably also need more attention and more research. So yeah, the access barriers I already mentioned, and the trade-offs. Then with regard to the development challenges, people also raised some concerns with regard to bias in algorithms, especially with regard to cardiovascular conditions. We know that there's a gender bias in the currently available data, but also, for example, in the selection bias in the study, potentially we are recruiting already participants who are more motivated, are from a specific background, which could also create bias in the algorithms of the projects. Then again, being aware of this possibility also gives you the opportunity to mitigate this and to take this into account. Something participants also voiced was the lack of public engagement with preventive medicine, that there's still a long way to go, both with patients, but also healthcare professionals, to make that switch to more like the preventive way of thinking, that there is a shift, but that it's not completely there yet. And also the long timelines you need for preventive outcomes to show, especially with projects like EIBIR and other projects often have a short timeline, where it's not always possible to also provide the data for these preventive outcomes on the long term. So long-term follow-up was also seen as a challenge when it comes to the development of these tools. The data heterogeneity, so variability in data storage, but also incompatible standards and formats, was voiced by several people, and something I think also we have seen within our project. So I think for the future, this is certainly also an area worth of attention. Then some participants also voiced the data quality of the non-validated health monitoring devices. So it's both an opportunity to have more reliable data, but some people also questioned what the quality of these data might be if they're not validated as medical devices that are being used until now. And then, of course, I think as every project, recruitment can be quite challenging. So also the limited data sets, small sample sizes could also have a limitation on predictive power. Then if we think a step further with regard to implementation, of course, we're still in the development phase, but if the tools would be ready and would be proven to improve also the outcomes we're looking at, we also asked participants what could be potential implementation challenges for the future. And there, many or several participants voiced that healthcare professionals can be quite reluctant to adopt new tools as outside of guidelines. So it's very important to see that these tools can be integrated into existing workflows and also clinical practice. Also, all these different silos was something that was voiced, to not have like an app for cardiovascular conditions, an app for diabetes, but to have something that is more integrated, especially by those active in the clinic, because they also said, like, when we are seeing our patients, we're not going to open 10 different systems. It has to be practical, of course. Also, with regard to the future implementation, that there will be a need for also interdisciplinary collaboration instead of a narrow focus on individual responsibility if you use this kind of tools, because of course you can provide patients with a risk score and you can have more personalized lifestyle advice. But of course, we know there's also more broader structural and environmental determinants of health that should also be tackled if you want to really make a difference. Also, with regard to implementation, again, these access barriers and sustained engagement were mentioned. And there it was very often said that for it to work, it should be user-initiated, that patients should really the intrinsic motivation is very important if you want patients to use this tool on the long term. With regard to access barriers, that you have to take into account that language, for example, but also certain age groups, socioeconomic backgrounds could also potentially mean that some groups still remain underserved, so that you have to take this into account also when implementing these tools. And then again, with regard to the appropriate point of care for implementation, it was sometimes also questions: who would be the end users, the real end users of these tools? Is it a GP? Is it a cardiovascular doctor? So who is going to use these tools? But there it was seen as something that would be interdisciplinary, but that's something that still also needs the attention. So some participants said, we know from that research population, so patients living with obesity, that if we use apps, the ones who keep using it are the ones who are the most motivated. So the question is, how can you motivate the other group? So in conclusion, some take-home messages. Overall, the AI-pod tools show promise for obesity cardiovascular risk prediction. Depending on the interviews we had with stakeholders, but there were several things that were voiced that are necessary to take into account. So equitable access, trust and transparency, sustained engagement, make sure that the clinical integration can remain smoothly, and also the context-sensitive design to avoid stigma. So that's in a nutshell what I wanted to share with you today, and I'm happy to answer any questions during the plenary session. Thank you.
Thank you very much, Eva. Very interesting views from the survey responders. So I would like, and I really thank the speakers that they kept in time, so we have more time to discuss. I ask the attendees again to put your questions, I think, in the chat. So the EIBIR officer will help us to show the questions, so we can address the ones that we can address at the moment. And I also would like to ask the panel to feel free to interact, because I think it's good if we also hear the discussion among the panelists. So while we are waiting for the questions from the audience, I would like to give a general question, like to any of you to answer, or more of you. So we are familiar as a doctor with clinical decision support system, and that we're really in need to help us to have a tool that can confirm or give us better guidance for the right treatment decision. The ones that are especially important in preventive medicine is if we could expand not only to the end user clinician treating physician in hospital, but also to the say the Gen Z generation, or the new generation, who are more aware of preventive medicine, I would say. And I also believe that this tool, if used by the generation that really care for their the life expectancy, who will be more willing to adapt their lifestyle, because they are already doing so, right? It's already more common than in the past generations that people are very much doing sports, etc. So I would like to ask you, also because of its biggest impact to prevent the disease, if someone, a citizen, would observe using this tool that he or she has a higher risk for cardiovascular disease, is there a vision, a system in place, or a vision from the project leaders how we should follow up on that? What is the follow-up system of this? So does the citizen, knowing that the risk is very high, needs to go to the GP or to the hospital, or how, if the GP, how are we going to communicate and explain the value of this system to the first line medical care, like the GP or the nurse at the GP? So can you elaborate on whether the group, the project group, has already addressed that, maybe for the future beyond the project period?
I could maybe from my perspective as physician, look, I think AI-Pod is not just a project, it's actually a movement. And I mean with that because we physicians are also humans too, and we are part of this generation also. They are the young one and they are the older, experienced one. And when you get older with time, you rely more and more on your experience. And when you're a young physician and started confronted with daily cases, whenever you need guidance, you reach to these one-size-fits-all guideline models. And the elegant thing about this project that makes more individualized approach. However, this movement should also get inside our heads as physician, as someone who treats patients and also patients. So we should also, I think, emphasize the idea of using these track devices, maybe, or at least read about it. And I think from my clinical experience of my colleagues is that we are more and more getting confronted with people who are a normal patient is very well informed about his health. They could explain their cardiovascular, they train after heart zones, and they track their ketosis level, and their sensor, they are using sensor either, although they are not diabetic. So I think we need this individualized approach. We need also to implement it in our daily thinking and address that. So we need to be actually ready for these well-informed patients who confront us with the data they gather. It's a huge amount of data they're measuring right now, and the technology brings it with them. So yes, of course, we need it. It's a movement in all dimensional, also to us treaters.
Yeah, so you're referring to the patient who have already had the diagnosis and maybe also the treatment, so they may be very much aware of the disease, but also the risk, and very much interested in how they can change the lifestyle. But for the healthy citizen, if we are talking about preventive medicine, what is your view on this, the use of the AI-Pod kind of systems for their life to change and adapt their lifestyle?
I can maybe also add to that, because I think with an AI-Pod at the moment, we're recruiting patients that are over 50 or 55, Anastasia. I am not exactly sure you will know better.
45.
Yeah, so it's another age category, and it's actually also patients living with obesity, which is already a chronic condition with an elevated risk for cardiovascular conditions, right? So I think if you think about primary prevention, it also came up in our interviews that some people also said like tools like AI-Pod would also be very interesting for primary prevention, to have patients or citizens with an increased risk to develop obesity, that they know when to reach out to a GP or a specialized doctor. But I think that's something else what we're doing from within the EIBIR consortium. EIBIR consortium is really aimed at patients already living with obesity that are being referred for a CT scan. So it's not that group that you are referring to, but I think there's certainly value also in AI-based risk prediction for primary prevention in patients that don't have the condition yet.
Yes,
if
exactly.
that answers your question.
Yes,
Yeah.
it does. It does. And is there any? Because I can imagine, and I would find it a bit of pity if this is a project only, but you're always thinking about the period beyond the project. Is there any initiative that is being considered now to go into that direction? Because I believe that that is also a target population, a citizen that could benefit very much from this. I mean, you know, there is the younger generation, but also the generation that know that in their familiar, in their families, there are more risk people with risk factors for cardiovascular disease. So, is there any kind of ideas to go into that direction and seek funding for an extension or expansion of the project?
So maybe I can very briefly only answer to a couple of points. So one is that definitely there is the plan to continue, first of all, with the current running study, but then also one of the follow-up activities that we envision is that right now the study is about getting the data and getting these prediction models to run and to be reliable and having the evidence that they are actually predicting something that's correct. The next step is definitely to also provide these prediction models to the users of the variables. And I think like in that context, we could also think about or should think about kind of expanding this kind of the addressed population. And there are now screening projects that are starting at a much earlier age range in order to be able to see very early signs or very early kind of signatures that might turn into something that's actually predictive for something that's relevant for prevention. So I feel that our project might also go into this direction in the next steps. One of the next steps that we for sure want to make with follow-on funding is to turn from the current project phase where we are developing the risk score, where the end result should be a risk score that is reliable, to something where we can provide this risk score to the study participants in order to see how they use it in real life to make lifestyle decisions, but also kind of connected to GP visits and other points that might basically escalate a bit beyond just lifestyle challenges if there is something out of the ordinary.
Yeah,
And
Jan.
and maybe building on this point, I think especially just like Georg said, as the algorithms are already built in a way that they can also be used as part of clinical decision support, as part of the medical device regulation. So it's really made so that as soon as the evidence and all of that is there, that you can actually roll it out to more and more physicians using decision support systems. So it's sort of this ecosystem idea that's is a big part of AI pod. And so excited how this will be used in practice in the future.
Thank you. So there is a technical question for George. Why did you not use MRI in this type of model? So one of the attendees asked that.
Yeah, that's a very good question. So part of the method development, we actually looked at MRI because definitely there is a lot of information about the muscles and the myocard in MRI data. In this specific project, we focused on computer tomography because in these cases it's more widespread, and we were particularly interested in what we can gain from very high resolution and multi-energy, so from photon counting, computer tomography, because that's also one of the technologies that promises to give us more resolution, but also to give us less radiation exposure. And part of the project was also to explore how much can we gain out of this data of these scans that are fairly fast.
Yeah. So you're mentioning, George, photon counting. So one of the questions is, how long will it take to have enough data from this type of scanner?
I mean, I think like what we are seeing right now is that it's very rapidly increasing the amount of data. So I think like in a couple of years we have enough, but one of the specific strategies of this project was that we say, well, we have a prospective study that is running on photon counting scanners. So all of the centers that are involved in the study are actually working with photon counting scanners, and there are quite a lot of cases that are scanned with that. But technologically, what I showed you about this transition using models that were trained on data and then transitioning to new types of scanners, I think there's a lot of value in that. And we see that if we take models that are trained only on modern scanners and compare them to models that are, let's say, pre-trained on older scanners and then transitioned to the new scanners, these models are better. So they can profit from slightly different scanner data if the methods are able to kind of separate or disentangle the variability that is coming from the scanner technology versus from the disease and the biology. I think it's definitely an issue, Kat, right? It's new technology and kind of the case numbers are ramping up right now, but there is not a lot of retrospective data on photon counting CT scanner, of course.
Yeah, and I fully agree that you need to continuously adapt the model because also the technology is evolving, right? So we have photo counting now, but you never know what will be there in the coming years again. So, but
And I mean,
it's new.
exactly.
Yes.
No, I just wanted to say that's totally true because also like it's not this one jump to photon counter scanner, but because it's so new, there are updates made to the scanner because also the scanner manufacturers are tweaking and optimizing the reconstruction parameters and all of that. So I think this need for models that can adapt to changing data is really important.
Good, thanks.
And maybe I can add here, we are also testing a new extended photon counting CT protocol for cardiac CTs, just to gain even more diagnostic information out of the scans. We are also combining them with new post-processing tools to see maybe what the plaque composition can tell us more about the patient. And all of that flows into the risk prediction model. So we are trying to really use all of the photon counting's capabilities. And of course, we're trying to improve it over time.
Thank you, Anastasia. And a challenging question for Eva or statement. One of the attendees state, I have to disagree, Eva, independent of the AI recommendation, the most important recommendation will always be to reduce calorie intake. Although that said, she truly admires the pioneering work that is being done here. Can you comment on the disagreement statement?
I think, of course, there's what I would like to underline once again, this is not my personal opinion. It's what stakeholders voice out. So it's clinicians, but also other people. I think when it comes to obesity, like I think we know that diets and calorie intake on the long term is not always providing the outcomes that we would like. I think we are learning still a lot. Not saying that calories don't matter, but I think obesity is a chronic condition that is very different factors that play a role. And yeah, at the moment, I think, especially with everything that is going on in that field of research, I think there's still a lot that we don't know. I'm not sure if I have the answer. I'm also not a clinician from a background, so don't feel I'm really entitled to make hard claims at the moment. But I understand the comments. Thank you so much for that question. But I think there's still more debate, necessary and more research. I think especially with regard to all the weight loss drugs that are currently also a very hot topic. I think we still don't know everything behind the mechanisms of obesity. So I think it's not only about calories, but calories definitely also play a role. Like behavior is also one of the factors. Yes, I hope that answers the question. But again, like it's not my personal. I'm just presenting what came out of the interview data.
Yeah, but it's exciting because this all helped the field to move forward, right? So
yes. especially, and I think finally we are at a moment where we can really also help this patient population. I think for a very long time there wasn't really any steps going forward. I think it's a very exciting period in time where we can also help, and it's becoming more and more a problem worldwide. So I'm very happy with all the steps that are being taken in the right direction, for sure.
Good, good. There's one question for you, Fabio. Are you aware of other apps of this kind from big tech? From an entrepreneur perspective, how will you distinguish your product from other products?
So it's a very interesting question. I think there are many apps around that collect data on lifestyle, behavior, etc. But they are slightly different because they are not within a scientific study. They are just business to consumer apps that secretly collect data about you and then use that data to earn money, basically. We are slightly different. We do not do anything with the data, of course. So we, as a company, we have more similar projects like this one, different types of data, different types of pathology. But our business is not harvesting the data. Our business is being the conduit to collect that data, link it to scientific databases, and then reuse it for scientific studies, for example. I think that's a very different business model than all those other big tech app developers that try to earn money with the data. We are in a totally different world, I would say. There must be others like us. I am not aware, but there must be. I know there are some CROs, so research organizations that do build apps as well. I think we are one of the most specialized ones because we have focused specifically on this patient engagement part of scientific research. But there must be others, of course. I don't know them by name, but yes.
And that's only a good news, right? Because we need to work on this and evolve it.
Yeah, ideally, in a perfect world, this type of data collection would be subsidized in any way by the government, or it would be pushed by legislation. Insurance companies could play a role. You see that sometimes hospitals actually try to set up projects like this, where you engage your patients a bit and try to help them. But hospitals are not very good at IT projects, so usually it doesn't lead to really scalable solutions. But yeah, it's an interesting dynamic.
But we're getting there. We're getting there. I'm
slowly, yeah.
So there is another interesting question from many attendees. That's how do you make sure that the lifestyle data from the patients are given correct? And the other statement is, in my experience, obese patients are quite aware of their disease. Non-compliance is most often based on behavior, not on insufficient knowledge of risk, which I think that is a very interesting and true statement, I think. So can any one of you maybe comment on that or give your vision? How do you make sure that the lifestyle data are given correct?
So I can say a bit about it. So 100% never, because it's still the end user that has to input it. So if they want to cheat a bit and do not confess that they have just eaten the whole cake, then yeah, I mean, we have, but I assume that since we made it quite easy for them to register it, and our sample size is big enough, I assume that the results will be valid, and the spread will be big enough, I assume, to deal with slightly small pieces of missing data. But of course, unless you put a video camera somewhere in the kitchen, you will never be able to have and even then you will never have a 100% coverage of everything they do. So
of course, so the larger the scale of input, the better. Yeah.
Yeah, of course, yes.
Yeah.
maybe I can also give an insight here. So we have a specialized group within the projects, the so-called super users, who are just there to take care of the patients, of the study participants. And whenever they enroll a study participant, they always clarify that we're not here to judge. We are just here to collect the information, and the more honest the patients are, of course, the more reliable the outcome of the entire project will be. So we just make sure that they understand that this is not like a surveillance project. It is more of something they can benefit from, and not only them, but also others. So whenever they help us, whenever they are very honest to us, they are actually helping others in the future as well. So it has a great impact, whatever they're doing. And I think this is a very important aspect for them. And also that's something that drives their motivation, because they understand that whatever they're doing is not just for fun or for judgmental purposes, but it's because they are trying to improve future healthcare as well.
Exactly. Well, 1.5 hours flies, so we are exactly at 10:30. So I would like, first of all, the attendees to thank you for joining this webinar, because I think it's important to understand what's going on, and it's also exciting. I would like to thank all the speakers and congratulate you for everything that you've already initiated so far, and you're still ongoing with your project. And at the European Congress of Radiology, we will hear more about this. So I would like to thank you from the bottom of my heart and wish you good luck with the continuation of this project. It's very important and very exciting. Thank you all. Bye.
Thank you very much.
Thank you so
Thank you.
much.
Thank you.